Welcome everyone to the Return2Play podcast. I'm Aaron and I'm here with George, the owner of Pathos PT. He is a very important piece of our Return2Play ecosystem. He is one of our physical therapists that is going to be encouraging people to get back to the activity rather than the other side of things, which is kind of ending up encouraging people to stop doing whatever that is, whether it's skateboarding or something a little bit risky. We find a lot of people are kind of being discouraged these days from doing some of these slightly risky activities just because you might get hurt. That has led to us sort of having a bit of a fragile society. So we're here to kind of try to change that. So I want to let George give us a little bit of his background and how he kind of came to be that type of a physical therapist that aims at more of the encouraging side rather than the limiting side.
Okay, so name's Dr. George Pathos. So practice Pathos Physical Therapy. I've been practicing for about almost 5 years now in the state of Florida. And really the whole premise is just kind of remodeling or reviving physical therapy as a whole or as an image that it's seen in the community. Unfortunately, physical therapy has kind of taken a little bit of a stagnant impression on society as a whole. So kind of seeing like when you see physical therapy, you kind of have an image of like a medical office or like the same kind of similar exercises, same form of treatment, or maybe just even seeing it as something for geriatrics or like older generation, whereas physical therapy can be seen more so as a full-on lifestyle change. Addressing some of the people that aren't targeted as much, a lot of the younger population that lives with that pain, and taking them at that point where the pain's starting or it's been going on for a couple of years and getting them back into the activity before it's kind of too late, in a sense of like, you know, when you start to have pain, it can start in like your 30s. And if you don't get it addressed, this pain can go on for pretty much the rest of your life until you're, 60-something years old, and you're like, I've always had bad knees since high school football and everything like that. So then you kind of missed out on all those opportunities that whole time because you thought of that pain as that was kind of it, never got a fix, and just stayed at this level rather than getting up to a higher level you could have throughout those like golden years, basically. So pretty much getting after patients at that age rather than waiting until they get to the normal PT range that we see, like 60s and above.
Love it. Yeah, it's a big piece of our Return2Play thing is encouraging the play side of things. So if you feel like, oh, I got injured in my 20s, so I stopped playing the softball league that I liked, and that was, you know, the activity that kept you active. Now you might be entering that phase where every year you're gaining 3 pounds because of that less activity. Decade goes by, there's 40, 50 pounds added on. Now you're adding stress to those bad knees and they just wear them out. And now you're gonna call it arthritis. And now you're gonna get your knee replacement. So the second you decide to stop playing the thing is the moment that your body starts to just slowly wane. You start to build that extra weight load, and now those joints start to give out because they're not tissue tolerant of anything anymore. You're not jumping up and down, so there's no plasticity or pliability anymore in your, meniscus or the shock absorber of your leg, so you feel like you can't do anything anymore. Getting on the ground is a hard ask. Yep. You sigh every time you're like, you want me to get on the floor? I'm like, you're 40.
You're 40, you should be able to do it.
You shouldn't be groaning when I'm asking
There's
about
80-year-old guys out there that can pretty much do burpees.
Right, so it's just a matter of the activity you've been doing throughout your lifetime. So we don't want people to stop doing the thing that got you hurt. Usually that's the last thing you want to do, especially if it's something you love.
Yeah. Exactly.
I love that.
You can always find a way to do it. I mean, you see people out there that like Paralympics, for example, like they're still doing that sport, running and swimming or whatever, with no arms or no legs or anything like that. Like there's always seems to be a way.
That's right.
So.
And I think some common misconceptions when people are dealing with pain is a big topic we wanted to address today. That's a little bit of both of our specialties. So first thing I wanted to talk about was, stretching. A lot of times people feel they just have to stretch it out when it's hurt. I just need to stretch and let it rest. I wanted to get your thoughts on rest and stretching as the main way of dealing with this ache or pain while it recovers. And is that the best thing to do, or is there something else that you would recommend your clients to do nowadays based on some more recent findings?
So overall, I go into the science of like majority of the studies that study the physical therapy treatment, whether or not it's like exercise alone, manual therapy alone, or the combination. And those studies explain that combination is always better than one alone in a sense. So whether it's stretching alone or exercise alone, the combination ends up being a little bit better than just one of them alone. But really for stretching, when it comes to pain, you go down into the science of what stretching is and what exactly stretching is doing to the muscle. If you go down really into the anatomy and the physiology, you're activating the Golgi tendon organ of that muscle, which as you activate it, it's causing that tightness effect when you try to stretch as a protective mechanism to keep that muscle from tearing. And essentially you're just pulling that until you fatigue the GTO, and that's what allows that increased range within that muscle. But the thing about that is it's temporary effects. So that Golgi tendon organ, it fatigues, but then it recovers. So after that fatigue, it's like, okay, that does feel a little bit better. Like I got more range, my hamstring can go higher. But then later on, after a while, just kind of goes right back into where it was. It gets back into that protective mode, which is kind of what that muscle is supposed to do in a sense. So study-wise, temporary effects, it does improve, but then long-term effects, it really so.
And that's kind of where doing the stretching and the strengthening in conjunction can really allow the body to reset that protective tension that it's experiencing and help your posture kind of realign to a more acceptable degree of motion. So now when you walk, you run, you lift, you're not dealing with those same mechanical stresses anymore, but you can actually strengthen the tendon and the tissue load capacity to a way that's not aggravating anything.
And exercising it too, you end up warming that muscle up to where it actually does get into increased range without even really needing to stretch. And you really don't want to stretch a cold muscle.
Right.
So.
Right, and the blood flow that you get from some of the exercising the area, versus just stretching it, you might get some tissue pliability back, but the blood flow that you get from exercising the area does tend to add a lot of benefit, especially if you're dealing with like ligaments and tendons, right? Those don't typically have a very good blood supply. So any way that we can encourage a little bit of new blood flow to get that area, sending those helpers to remove the debris that it needs to heal that process. That's kind of why you ice and rest, or ice and heat is to create that cycle, right? It's not just ice and leave it there for an hour, because that kind of defeats the purpose. We want to encourage good blood flow and then get it out. Good blood flow, get it out.
Yeah, circulation.
So stretching alone typically isn't going to be your best solution. Finding the right type of activations and or corrective exercises to help facilitate that new position that you want it to accept, whether that's a new deep squat or a position a little more complicated than that.
I mean, me personally, I've had a lot more benefits from pretty much eccentric loading or just exercising that muscle than just full-on stretching it, because I had a lot of issues with hamstring tightness, and I used to just stretch it, just cold stretch it all the time, and didn't really help as much. But getting into exercise that forced it into like a lengthened position and then activating it, I've had a lot more benefits.
Why would you say that when people feel that something is like tight, what would you say that they're really feeling? I know sometimes it's not just that something is restricted as far as length tension wise, but there could be other things going on.
A couple different things. Part of it could just be that muscle, like I was saying before. It's just a protective mechanism because really it was not put in that position for maybe a long period of time. So being in like for example, if your primary position is sitting in an office chair at work, the hamstrings are gonna feel tight. Your back is gonna feel tight because it's stayed up like this all the time. Once you bend over in a different position or extend, it's gonna be a different position than it's used to. It's gonna keep it in that position because it's not used to being in that much range of motion.
So would you agree that it's essentially showing you that it's a weak spot for that range of motion and there's some kind of strength necessary to get that tightness to subside?
It could be a sign of weakness too, just because that muscle likely is not being activated or as strong. And a lot of times with tight muscles, it doesn't mean it's a strong muscle. It doesn't mean it's a strong muscle. So with like stroke patients, for example, where they have like a contracture and their arm's stuck like this and you can't even pull it out with your own arm to get it into extension, it may make it seem like, oh, that's a strong muscle, but in actuality, it's like that muscle's actually weak. It's just contracted. But the muscle actually is considered weak. So that's just kind of every time you think it's like, oh, tight means it's just like strong, and that's not really the case.
I find it's usually the opposite. It's kind of indicating to me, I'm like, all right, there's some kind of strengthening exercise I need to come up for that particular thing you're feeling.
Or it's not functionally strong. Think of like bodybuilders. Bodybuilders are like super tight, and like the main muscles like biceps, lats, and stuff like that. And yeah, they're strong for that short range bench. But you take them into something else, like a pull-up, you take them into like some of the calisthenic motions, they can't do it. They're like, where is this?
They're night and day. They're like, man, I'm so strong in the weight room, but like, yeah, you guys got me here. I'm feeling like I'm on day one with some of this stuff, and that's ranges of motion they're just not familiar with. And with
takes them neuromuscularly.
It's high range of motion, almost every exercise. Big factor. So I definitely agree on that one. Give me your thoughts on, okay, I felt this thing happen in the gym. The movement I was doing was a deadlift, so now I'm scared to deadlift. And I think the movement of a deadlift is not a good movement now. What would you say to someone in that position? Was it really the movement that was the issue? Was it more of a cue that they just didn't think of? It's not really the movement they should be blaming, but maybe something that they didn't know that they needed to do that caused it. And you could be coached in a way to still do that movement in the future effectively without re-injuring whatever you had to heal from. What have you experienced with that kind of
typically, like if I have a patient that comes in that mentions that, it's understanding, one, fear avoidance, and two, understanding sensations and its correlation with pain. And like if your pain, especially with like older patients that I have, they're like, oh, that hurts. And you're like, okay, is it like a sharp pain? Is it like a dull ache? What makes it hurt? And then once you get down into it, you're like, oh no, that's just, you're feeling the muscle engage.
Yes.
You're feeling, that's called a quad extension. That's just your quads are activating. It's not pain. It's just, that's, your muscles are just weak and they're burning up sensation because you're activating them. So understanding that, but also understanding when it goes into that, oh, that was a sharp pain. That was a pain similar to when I had my injury. Why is that going on? Is it the position that you're doing the deadlift? Is it the amount of weight that you're doing in that position? Are you starting to compensate because the weight's too heavy? And that's really why like personal training and physical therapy are so important, because if you want to get back into that, but you want to do it right, it helps to have someone else guide you through it. Even myself, I need like a camera and stuff like that. I can't always tell if the bar is leaning to the right or left. Like, it's really helps to either have someone call you out or have a camera. So.
And I try to encourage my clients, same thing. I'm like, if you're in the gym, don't feel weird pulling the camera out, at least on like your top sets, because that's really where we're going to be able to tell like what's happening. So you don't have to pull your camera out for every single round.
When it's heavy. Yeah.
Once you get to your heavier load, film a rep or two, or at least, a set or two. Maybe that's something you send me if you're unsure if it looks okay. But when you see people in the gym with a camera, they're not always doing some kind of TikTok, Instagram thing. But we would actually encourage you to do so for a sake of form check on yourself, because that's really the biggest thing. You might feel like you're doing something, but when you look at the camera, you're like, wow, yeah, I wasn't doing it. Even though I felt like I was sticking my butt out into my squat, I was still butt winking before I even broke 90 degrees. So something wasn't engaging properly as I descended.
Exactly.
So it was more the dosage, not necessarily the movement, that created this injury. So you don't need to be afraid of the deadlift. You just now need to ramp back up to doing the deadlift in a proper progression sequence and weight.
That's a big thing too.
So maybe you go back and you're doing, partial rack pulls before you start descending below, too much past your knees. So you start to restrict your range of motion back and then build it back over time. There's a lot of different ways you could play with that, but understanding it's not necessarily the movement that's bad. I don't really think there is any bad movements or exercises. It's more just that's maybe not a good exercise for you right now. And maybe you have a lot of work to do before I would recommend that exercise to you. So it might seem like, yeah, don't ever do that one, or at least not for probably 2 years until we have the range of motion of a gymnast, and then maybe we'll practice those. But
yeah, I have patients that I work with that are like runners coming off an injury, and then they'll ask like, can I go back to running and stuff like that? I'm like, you can go back. Like, I'm very big on getting back into running as quick as possible, unless it's something that I'm like, I think that if you run, you will 100% get injured. I'm kind of all for running, but it's to a discretion. Like, all right, try running for like 5 minutes on, 5 minutes off, or 10 minutes on, 10 minutes off, 30 minutes on, 30 minutes off, and progress into that, rather than me say, go ahead. And then they go and they're like, oh no, running hurts. I'm not ready to run yet. It's like, no, you're ready to run, just not to what you're
not 26 miles yet.
Yeah. Don't run. I have one patient now that it was like second session, had this pain, hasn't run because of the pain for like years. She's like, I signed up for a 5K on New Year's. I was like, all right, okay.
This is quick, but
I had no say in it too, because she's already signed up. I was like, okay.
Well, if you feel you need to walk it,
I was
feel like you have to run. Maybe
just run, walk then, or just, gauge yourself, understand I told her kind of the stuff of understanding what you're feeling when you run and stuff like that. If it's a little like achy when you first start and it gets better, that's a little different than like you had a sharp pain in the area we've been working on, what to look out for.
I think this is a perfect time for us to segue into some of our chats that we do at the Return to Play program, is pain definitions and understanding the language to use with us as a practitioner, so that we understand how to adjust this exercise or release whatever it is that we're doing in the moment that could, still be something we could do, but maybe we just adjust your positioning a tiny bit, or we add one more piece to it. So we have a talk where we go through, these pain rules, and one of them is kind of understanding that if the pain number reduces with movement, then it's probably okay. So like if you start out and you're like, okay, it feels a little tight on the first rep, it's a little less tight on the second rep, and then it goes away a little more on the third rep, it's probably a movement that you're okay doing. Just ease into it and maybe warm up properly for sure. That's not necessarily something you need to avoid it just because you felt it on the first rep or two. As you're saying, if it was like a sharp sensation or something, that's different. That's telling you, okay, yep, that movement's not gonna be a good one for you to do right now. So what do you also kind of chat with your clients about so that they understand how to talk with you? Because I heard you say too, like your older clients will just say, oh, it hurts. And we have another one where like, tell me, is it stiff feeling? Is it tight feeling? Is it sore feeling? Is it numbness, tingling, burning, something I need to worry, like a nerve is being pinched? Language like that really helps me understand what's going on in the area of concern and how I can maybe help continue to do some movement without having to just stop. Telling me it hurts, I'm just gonna be like, I'm just gonna have to keep digging deeper. So the more I can get them to understand this stuff earlier, they're just gonna use the language appropriately so we can have a much more efficient session.
Yep.
So do you have any other couple of rules that you add on to those couple maybe, or a couple of extra pieces?
Similar to that. I think it also, taking it as a whole, it does help train them to learn how to describe it, which helps because going to someone else, like a doctor, and saying it just hurts, and if they don't dig deeper into it, that's what gets into the like pain medication culture, or just them being like, okay, stop doing that motion then, and not understanding that it's like, oh no, that's just, it's getting into what is actually painful or what they're actually feeling. So usually I just ask them to try to describe it themselves. And if they have trouble describing it, then I ask descriptive terms like,
does it this, does it that?
Yeah. If it's kind of like burn, then I ask, is it like a muscle burn? And they're like, yes. And it's like, okay, we're just activating that muscle. That's safe. That's fine. Is it the muscle that we're actually focused on? Is it the quads during quad extension? Is it the abductors during like squats? And then if it's something sharp, that can indicate a couple different things. It could be tendinous, could be ligamentous, a couple different things. Just depends what they're doing and the dosage, like you were saying, the amount of weight that they're lifting and stuff. I kind of look into that. And that helps me decide, okay, is it sharp? What intensity is it? Usually I just have them shift their knee a different area.
Yep.
It resolves. Then that's like, okay, that was the reason why.
It's a postural or positional thing.
Yeah, and then soreness is just something we kind of just think about, okay, different factors is like, did we work out today earlier? Did we do manual before we did our work?
What did yesterday look like?
What did yesterday look like? What's our stress levels? Everything like that. So, but that helps in the session guiding into when they work out, and then they're like, oh, this is sharp, he had me do this, and it went away. Now that makes them think like, okay, maybe it's just the position I'm in now, rather than totally shut it off.
Yeah.
So it's a lot of psychological training with it.
It's dealing with people that are in pain. It's a lot of, your body protects itself psychologically, just as we were talking about protective tension in the joints. There's also psychological protection. And I have, in my animal flow class, I noticed some of these movements, some people can do them on one leg and not the other. And a lot of it is psychological, whether they injured that knee in the past, or it's just atrophied to a point because of the way that they walk, that maybe that particular twisting motion is just being super highly protested while we're trying to learn this move. And I can see their leg just collapse every time. They can't keep the leg straight because they don't have the confidence in the ability to maintain a straight leg while they're pivoting over something. So developing some of these, skills that allow you to feel those differences left to right, or these movements that allow me to be like, oh, you could do it on the one side, what's up with this side, is a big reason that I have animal flow and steel mace flow and some of these other things in as classes, is because they were great assessment tools for me as a coach to help my clients understand, like, oh wow, well, I feel like a completely different set of muscles engaging when I do that to this way versus this way. And now I know a few extra pieces to deep dive and find out, how can I help strengthen the thing that's not turning on effectively. I think another one, I'll get your thoughts and then I'll share you ours, but what would you say is like acceptable pain ranges to let your client know, like, okay, it is kind of all right to continue working through, or maybe this is now at a point where I should say something to George and let him know, like, we should either alter.
Pain scale, you mean like scale 1 to 10 kind of thing?
I guess then
it's all subjective. It's like the people that walk in calmly and say they're a 10 out of 10. Yeah. So sometimes I'll base it off that, like if they have an initial, or I'll ask them, when they first come in, if you're struggling with pain, what's your pain level at its worst? What's your pain level at its best? So
kind of get their at least initial fluctuation. Yep.
So that way you can be more realistic. But typically for me, probably 4 is about the highest. It's 0 to 4 is a good range. Yeah. But it just depends. If their worst pain is a 10 and then their the lowest it ever gets is a 2, then a 4 is actually not that bad. It's a more 5 might be okay.
Right. So. And that's pretty in line with what we've landed on. If someone comes in with a 4, I'm gonna want to pull out my voodoo floss, or I'll think of some kind of specific stretch or activation to try to help shift that tension down before we go into the rest of the main focus of the day. If it's a 3, we may be kind of just monitoring it at your warm up. Did it ease off as you warmed up? Okay, now it's a 2, we're good to go, let's continue on with the session. If it moved up to a 4, then I'd be like, all right, this is something maybe we want to look at. Maybe I need to referral moment. Maybe this is a, hey, let's have you go see George for 3 or 4 sessions. He'll help you figure out whatever this is that seems to be getting more aggravated with this couple of movements that we've been trying versus getting better. I would outsource and have you kind of spend a few sessions, and then they would come back, and then I'd be able to dabble with whatever next phase of things. But that's really what I want with the Return to Play ecosystem, is this ability to understand when it makes sense to refer out to which particular practitioner. Is this more of a, I need the dry needling, or is this, you need someone to adjust the hips back so that your pelvis is reset again? Or is this more of a deep fascia issue where I need someone that's gonna have that know-how and active release technique to get in there? So all those little pieces come from a different expert that really knows that better than I can do with, the tools I have at hand as a, trainer. So
yeah, I feel like I don't know what you would say is the level or the time that you're okay, it's time for you to go maybe check something else out. If that's maybe a pain level of or just if it's pain with every single exercise, or if it's a pain level of 5 with every single exercise, progression or regression is not really helping, or something like that.
Kind of like that. And if it's been, more than 4 sessions and I'm not feeling like I'm able to get some notches forwards, by that point I will have done, my passive and active range of motion. I will have done some strength and balance testing to see where we're at. All of that is aimed at trying to help reduce that, 4 out of 10 or so. If I got someone that came in and they're still at a 5 or more out of 10, that's probably still more acute than I'm wanting to accept as a client so far. So at that point, I would say either go finish your physical therapy, or let's go find you a few sessions with a cash pay physical therapist, because if they were waiting on insurance to send them to PT, they're just gonna get anybody. But I have a PT you can see maybe 2 or 3 sessions and then come back, and I think what we'll do here will be a lot more effective. That's more what I'm looking for. So if I'm getting someone that's still staying in that 4 or 5 out of 10 for that 4 sessions, 5 sessions, and I'm just kind of feeling all right, we're not quite ready for what we're doing in here, I'm gonna have you take one little step back, send you back to PT. They'll have a couple extra modalities to add into the mix, and then we can kind of keep the ball rolling instead of me spending 12 or 15 sessions and finding out, all right, this still isn't working. I kind of can already tell that by 4 or 5 that what I'm wanting to do isn't quite something you're ready for. So let's take that little bit back. Yeah, so I want to probably label it at the like 5 out of 10 on a consistent enough basis for like 4 with me, where I would be like, all right, it's time to refer out.
Consistently pain, yeah.
Because normally, and this is why I tend to also schedule my clients at least 48 hours apart from their last session, because I want to see how the tissues are responding to what we're doing. Because I know sometimes they'll feel great when they leave. They're like, all right, I was at a 4 out of 10 when I came in. It's a 0 out of 10 when I'm walking out of the door. I feel great. But sometimes this is another talk we have to have is, hey, you feel great, but that doesn't mean go do a bunch of more stuff today, because I probably towed your capacity line for that area to a degree where I've rebalanced your structure and your tension in the body right now. That's why you feel so good. Don't go ride the bike that we were agreeing on that maybe you need to just cool off, because that repetition is now going to potentially increase the capacity to a point where now you're going to have your tendonitis in your knees flare up again.
Yeah.
I had a client recently, same thing. I saw her Monday. She felt great Monday afternoon, and Tuesday she had some family come into town, so she was kicking around a soccer ball with like the nephew or something like that, and then she woke up and she was like, my sciatic was flared up so bad on Tuesday morning, but she thanked me because she felt so good leaving Monday that she felt up for doing that with them. But I had to just kind of have that talk again, which is, it's great that you felt good. That means we're on the right track, but you have to keep in mind when you're doing your day-to-day things that because I'm training in this type of way, we're using the area of concern, so I'm using up some of its capacity. So these day-to-day things like playing with the dog, sometimes going for that walk that you like to do by the water, sometimes that might be a little too much for you to do at the moment. So being really mindful of those extra activities. But she really was happy because she was like, I did feel really good for the first time in a little while, but so much so that she ended up taking a step slightly backwards now. So she ended up not seeing me today because of it. So those are moments we have to be very conscious of. So I'm sure you've experienced some similar.
Yeah, where you get that like post-session high kind of thing. And
their endorphins are going. They've been in pain for weeks, and they're like finally like, I finally don't feel it. I feel great. And then I go clean the entire house. This was another same client, different couple of months ago. Felt great, decided to clean her entire house. Sciatic flared up again the next day because she was just bending down, doing all the laundry and doing dishes and all these things where she was like feeling behind on because she was babying it. She caught it all up because she felt good, and then it just re-injured the issue.
It sucks though, because it's exciting, but then it's like, it's so much impact on their psyche with it too. It's like,
so much.
Because then they are so like 100%, their expectation of rehab results are like 100%, coming out of session, and then they end up doing too much, and then they kind of have it come back, and then their expectations just go back down. Now they have more of a pessimistic attitude, and they're just like, I'm gonna have pain forever. And I'm like, what did you forget about like
how you felt after
how you felt after, and like how to continue that?
I've got 2 clients that I'm kind of in a little bit of that cycle with, where we're trying to fine tune the afterwards, because our training is starting to show like the training is doing what we need it to, but it's the outside of here that is nipping us in the bud every time. As far as our progress goes. So just something everybody should be very aware about. If you are coming back from an injury, you have to be so careful when you're really focused on training it, not to do the silly things in your day-to-day. Sometimes it's, I've had clients with back issues. We're learning how to deadlift again. Things are going great. They've built up some capacity back. After a deadlift session, they don't think about it. They just bent down and grabbed the cat's bowl to feed them real quick, and they tweak their back while they're bending down. And then they think that it's the deadlift that was the issue. And I'm like, the deadlifts were fine. You were perfectly good leaving here. All of that was good. It was the lack of attention to the twist and the bend at the same time. You didn't quite breathe into it and brace. You allowed your spine to have this laxity again, and now if it was a disc bulge or whatever might have been the thing that was kind of flared up, just re-happened again because we weren't mindful of our movement.
It's the level that they're at that time, like post first session kind of thing, and the level of education that they have on it. So because they still have not figured out, that first session's pretty cluttered with all the info and stuff like that. They haven't totally figured out, these are the muscles I need to engage to avoid that pain for now until they get stronger. This is the motion that we have to do, or like the reason it just hurt when I just did this is because of the stage of healing it's at. Like, there's a lot of different aspects as to why. And not that we, like, that they're still like super vulnerable. It's just, I think the education that they have of it, or the understanding.
Yep. And there's, some application of what we learn in the weight room and when we're trying to learn how to just move again, where we have to really make an effort to apply those to our daily activities. There's certain mechanics that maybe he didn't send his hip back like he would have when he deadlifted. He just straight up bent down like a forward fold after doing all these deadlifts, and he didn't apply the hip engagement to help ease the load, and his back just had too much on its own, and that was just, lack of a better word, the straw that broke the camel's back, right? It was just, you weren't thinking about engaging the right things to bend down and grab that bowl. It was I'm just gonna reach for it, and you ended up just grounding fully. So things to keep in mind when you are stuck in these cycles. Try to stay conscious of it throughout your day-to-day. When I have postural corrections for clients, and I'm like, all right, your thing this week to think of is walking, but with this tweak. And then the next week, I'll sometimes add one thing. Maybe it's more shoulders back this week, and then maybe it's more like, oh, did you catch yourself completely 90-degree military ballerina pigeon-toed stance? Like, oh, maybe we need to pull those heels out a little bit and work on a little bit of your static standing position some. And trickling those into your day-to-day is really where the person who's in that chronic pain cycle, I think, gets a lot of benefit once you're applying these things you're learning to what you see yourself doing all day. If you constantly are finding yourself like this, you need to reset, catch yourself, or you're going to continue and just keep dropping farther and farther. So until you start calling yourself out on the things you're now aware of, no one else can do it for you. So this is the little bit of it's hard, because you're the only one that can start thinking of, oh, I need to hold my head up higher, or I need to tuck my chin a little bit when I'm in this position or that position. And something I've been pointing out on a lot of our initial podcast here is the reason we're sitting on the ground is encouraging a lot of these little movement nutrients. If you guys notice, every few minutes we kind of are shifting around because our body has hit a point of I'm a little tired
every few
there.
seconds. But...
Yeah, and it is something we're trying to encourage more people to do, because it allows you to get a lot of these hip opening positions just throughout sitting on the ground. You don't really have to think about it. Your body naturally is going to make you just shift around and adjust. Each position I've been sitting in has been a very nice, helpful opening position. It's just a matter of building up some tolerance to it. So getting my guests to try 45 minutes to an hour sitting on the ground, sometimes it's the first time they've done it this long in a little while. And I'm kind of wanting to see how, as I do this with more and more people, how many people come in and they might request a chair.
Sitting without a backrest is probably the main thing. A lot of people.
We expect a chair everywhere. It's definitely something in our Western
culture,
pretty much everywhere. You expect a chair.
The thing with posture, one thing that I actually, being a personal trainer, being a physical therapist and stuff, you get a lot of people that they either ask. I get a lot of patients ask about posture, and they're like, what should I do to improve my posture and everything like that, and analyzing the posture and getting them to make the perfect posture. And to be honest, I wouldn't say that there's the perfect posture, but actually saw that there is a study that went into postural training, and apparently forcing perfect posture training on people actually led to worsening postural tendencies and increased pain thereafter. And that compared to less or no postural training. And it kind of shows that there's a level of the postural training, so over analyzing posture can end up being more harmful to a lot of these patients, telling them chin back, shoulders back, glutes in, ends up being a little bit too much. So that's why I only go a little bit at a time. Like you were saying,
one little thing.
One session, maybe it's shoulder. You pick one little thing that I'm all right, that's definitely an issue that needs to be fixed. Not to make it perfect, but definitely is causing some of these movement issues and stuff like that.
It's more about just finding enough to where it will ease off of the gas pedal of the sensation you're feeling, just enough to where we're not getting any more of that feedback from that space.
Yeah.
Because you can definitely have a little bit too much of a extension here, where I could imagine it creates its own problems.
That's why the point you made about just sitting on the floor, I feel like your body just figures it out. It's just almost like you're calibrating it again, and your body just figures out, oh, this is the comfortable position for me. This is actually going to work for me, versus all the videos you see of just this is how you need to you need to do all these things to fix your posture. And it's sitting on the floor was one little feedback, and people can just figure it out, kind of thing. It's like throwing a baby in a pool. It just figures it out.
Figure it out. Cool. Next question. What would be a sentence that you wish clinicians would stop saying to their patients? I know you might have a couple.
Yeah, there's a lot.
Pick your favorite few.
So when you say clinicians,
Could be orthopedics.
Doctor, like kind of like orthopedic or doctor versus physical therapist?
Yeah, I guess so. Yeah,
Okay.
like if you got a patient from like an ortho or a primary that is now, I don't know, they were told, I know one of yours is like, I have shoulder impingement, they say, so
Yeah.
I needed to come see you. But that came from their primary care doctor, I guess.
I think, well, the number one sentence, which obviously is a little biased because I'm a PT, is that PT won't help. That's like probably the number one sentence to not tell people. And I know I'm a little biased, but I also believe that it's because how do they know? So
Unless you've tried, right?
unless you've tried. So I had one just recently. I discharged right before the end of the year, and that was a sentence that his ortho did say. He was an orthopedic surgeon. Basically, just to go into a little bit of detail, but he had something going on with his foot, and it was a pain that he's had for a really long time. He went to the ortho. Ortho said you can do a surgery, but I will warn you, the surgery is like very debilitating. You'll be non-weight bearing for like 6 weeks, and like you can't drive, you can't do all these things. And after, there's really no guarantee that the pain will be 100% better. So he said you can do that, but I recommend you don't. He's like, I recommend you not get the surgery and basically just kind of monitor the pain and just kind of deal with it basically. And his daughter really like pushed on him to be like try the PT, like do the PT. And so he went to the ortho and asked like, you know, can I get an order for PT? And he said, oh, I'll write an order, but I really don't think it's gonna help.
Really?
So that was like one of the things that he said. So, and then I saw him and he's like pain-free now. So like, it's like, at least try. I mean, when he came in and told me that he's like, ortho said PT can't really help. One, it actually makes a little nocebo effect for him, but it actually creates a tiny bit of nocebo effect for me too. Because I'm like, all right, if this orthopedic physician said that PT can't really help, who am I gonna, you know, try to tell him, oh no, it'll help 100%, and then it ends up not, and then I look more stupid in the end.
Right.
So, but it's just one of those things I tell the patient, I'm like, well, let's give it a try. But I'll look at it, and then by the end of the session, I'll tell him like, I have a good feeling it's gonna help. And then he's pain-free now. So it's like those little things.
Would it be helpful to now go back to the ortho and had that conversation and just be like, so this patient mentioned this when they came. I know you wrote the script for them, but I just wanted to talk with you on like why you thought that PT wouldn't be helpful. I don't know if it's
to be
worth
honest,
the squeeze,
it wouldn't happen.
You know?
It just wouldn't happen. The ortho would not take the time to sit down and basically argue or be proven wrong in a sense. It's more so what I did is even though I didn't really have to, I faxed him all the documentation of our final results basically. Cool. And just was like, here's all these things. I made sure to type in their patient is now pain-free, like just put in all those beautiful sentences and just send it to him. Basically it was like, here's the results, met all goals, pain-free, 0 out of 10, like just send them that. And that's about, proof is in the pudding. And the only more than that would just be the visit and be like, hey, I had one of your patients. He had really good success with PT. If you have anyone else that comes up, you know, let me know. Send me a referral and stuff because I had really good success with him.
That would probably be your best bet, I think, too. Yeah.
It's not so much, it's more so like if they say something like that, it's more of the sentence of like, I can't fix you, so I am assuming
that they can't fix you either.
That they can't fix you either. That this is the only fix that I know of. So it's more so that they just don't know about it, really. Or they just haven't really thought through it or anything like that.
And like if they're typically
ignorance
sending
is bliss,
people,
I guess.
Did they send them to you or did the client find you?
His daughter recommended me, so he went and asked them to send me a referral.
Got it. So it wasn't the ortho didn't already know of you to send it directly to you.
Yeah, he knew of me, but he just was like, okay, I'll send it over.
Gotcha.
So
he knew of you already.
The patient was the reason why.
But the patient was what found you. Okay.
Yeah.
Yeah, just curious. Yeah, and I wonder about that because like I'm wanting to try and help fix the challenge with the orthopedic and the physical therapy.
Yeah.
Gears that have been kind of just stuck in I'm only limited by what insurance can allow. And I had someone point out to me recently, and you can probably have a couple thoughts on this too, But some of the reason that some PTs are held back from doing more is because if they put on there that they addressed something in your knee, but you came in for a shoulder issue, that they would have backlash.
Yeah, that's the insurance world.
That's where I think we're having
world.
to see people do this cash pay switch, which is so that you can not have those ramifications. So I wanted to get your thoughts on, like, that's actually a thing. If you were only taking insurance clients, would you be forced to not be able to address the other areas of concern?
Pretty much.
So you're limited to staying very localized.
Whatever they designate in the order is what it is, kind of thing. Different insurances can be a little different. Like, you might be able to, I don't know, like, a lot of times you can kind of get away with it. Like, let's say they're here for their neck, but you do a little bit to their shoulder or something like that. Or if they're here for their low back pain and you have them do like a hamstring curl, that's all justified. Like, you can be like, oh, it's, you know, it connects kind of thing. It does help with the low back or something like that.
But if someone came in for a neck and you're like dry needling their feet,
yeah,
that would be a little too.
You can always find a way, but
I was like, you would just have to explain. There's meridians and this and that.
But it's more so like if they came in, it's more stuff like if they came in for like right foot pain, and you did something for the left shoulder. It's just there really is. Stretch. There's not much connection there. Yeah, that's a stretch there. So or like I had one that came in for their I think it was low back pain or something like that, or maybe whatever. But he had a lot of vertigo issues, and he's like, there with active vertigo, and I can treat it there. Vertigo is very successful to PT. It's like 1 to 2 sessions, and they're clear.
That's great.
Quick treatment, and you can't touch them because it's like. Can't touch the vertigo because that's not what they came in for. So technically, when it comes to insurance, it's only what you bill for. So I mean, if you don't charge them for it, it's kind of something like that. But that gets into some weird. Yeah. That gets into some kind of loophole stuff, and you don't really want to get into that. So either way, cash pay, you can kind of do what they come in for. You can continue on with that. You can get into more lifestyle change. They can keep coming in, they can stop, they can come back later. You just do so much with the cash pay, so it's
a lot more.
Yeah, and they can come in, like you don't have to wait on a doctor referral order, you just start, and like you don't have to kind of waste your time going to the doctor's office for them to diagnose you with low back pain. You can come in, pretty much it's becoming the first line of treatment, or the primary, first line of care. Which I think is the better way to go about it, because like if you're just coming in with low back pain, I would rather you start that care and me find a reason why we might need an MRI than to wait on that, get the MRI, and then usually they ask me, they're like, do you want the MRI report? And so, and if it does, I'm just gonna go about it the same form of treatment as I would if I didn't know about it. So unless it said that they fractured their femur or something would be the only, which I would find red flag signs and then refer them out anyway. So that's really the concept of it, is come in, if I see the red flags that they need to go and get that done, then I can send them out. We're still waiting, I can talk all day on this. We're still waiting with personal or physical therapy on being able to order imaging. We still can't.
Really?
Except in like some states like Arizona, they're considered primary care, like you can order imaging and stuff. Chiropractors can order imaging. PT can't order imaging.
I don't think I knew that wasn't I guess legitimate referral for that. I've tended to have to just tell my clients to just go to the imaging places that don't need you to have that. You're gonna pay $300 for the MRI or something. If you need the really fancy ones, it might be a little more than that. Like if you need all the crazy angles.
They have to go to their ortho or doctor first, and then they can go to the imaging.
Yeah, so if you're cash pay, you can just find one of the imaging centers and kind of not have to wait, because I agree. I've had clients that are like, oh, I'm waiting on the insurance to say, hey, yeah, you need this, and then you need to do this person first, and then now they've waited 6 or 8 weeks longer. The pain has gotten worse. It didn't really necessarily tell me anything different. I would have rather you just decided to go straight and get the image and not had to wait and try this or that.
Yeah.
And if the image said anything that would have changed what I would have done, it is more just to rule something out. I think, like you were saying, that there's not something crazy.
Yeah, typically with that, orthopedic-wise, it's just to rule out fractures and pretty much mostly fractures. Because anything else, like even meniscal tears, it is good to know, but it's still, you're gonna come back to PT, do the same form of treatment, unless you and then really, I can even decide if it's not responding from PT and I suspect a medial meniscal tear, they can get the imaging and then possibly get surgery if surgery actually is more effective.
Yeah, sometimes it's needed. You know, it's definitely not never needed. If you have a bucket handle tear in there, you're gonna have to get some kind of a piece removed out. That's gonna be a bit too irritating to just let stay.
Yeah, sometimes it can be more effective, and same thing with joint replacements. Sometimes sometimes PT, it doesn't respond as well enough from PT, and they're pretty good at replacements these days. So I always say try to avoid it. Like, try the PT first if you can, but...
Any other things that are hot topics that you kind of wish you don't hear coming from those other clinicians that you get in the door?
So that's like probably the main sentence that I would get from like clinicians, but I would more so get into what other physical therapists say.
Okay,
Because
what about them?
we are hurting our own profession, so we are our profession. So we even learned in school this term, and it's used amongst a lot of physical therapists, is just shoulder impingement syndrome. That's like a huge one.
Just calling it a syndrome, it makes it sound like it's
syndrome's like, syndrome in anything is just already, it's just all encompassing. It could just,
I'm gonna live with it forever.
It's shoulder impingement, it could be, or syndrome, it could be like irritable bowel syndrome. It's just very generic.
Doesn't tell you a whole lot.
Doesn't tell you a whole lot, and it's just generalized. It's kind of like, oh, you have a couple of the symptoms, then you fall into the syndrome effect. And shoulder impingement is one of them, which I think is kind of interesting because most of the actual tissue that's involved with shoulder impingement syndrome isn't even getting impinged, if you think about it. So like definition, shoulder impingement syndrome is essentially talking about the impingement of the tissues from the acromion to the humerus, because you have that spacing in between. Yeah. And that spacing narrows as you lift your shoulder up and it gets impinged. But most of these muscles are not actually going under the acromion. Like, for example, the anterior deltoid is above that area. Like, posterior deltoid's above that area. But usually when they come in with that, it's their deltoid muscle, it's their biceps muscle, and it's like not even getting impinged. So it's like, what's getting impinged then? So it's just so general. A better term is just defining what's going on in there. It's like, okay, it's a labral like issue. It's going on with the shoulder joint. It's the muscle, naming them.
Or it's like a bicep tendonitis.
Yeah, bicep tendonitis.
So a more accurate description of what's happening, not just the vague, kind of just overarching word.
Impingement syndrome, it doesn't list the actual tissue getting impinged, and it doesn't label why it's hurting. So like bicep tendonitis, it's saying the bicep muscle tendon is inflamed in the itis.
Yes.
There you go.
Yes.
That's it. Yeah. And that tells you exactly what's going on. And then we can explain why that's going on. So like...
Couldn't agree more.
It's just so many better terms. So shoulder impingement is like kind of terms like that. The stuff PT should kind of stop kind of saying.
Go the extra mile. Let the client know what's actually going on.
Yeah. And then I think a lot of PTs still believe in like avoiding activities and stuff like that.
So like the amount of rest.
Yeah, resting and stopping running with plantar fasciitis. And like limiting because we've had all these protocols like after an injury and stuff like that, like ACL tears and everything like that. And we're finding out that people can actually jump back into a lot of these sports a lot faster and safer than before when we were so like conservative with it. So
I think that's definitely a big element. When I was doing my athletic training stuff in undergrad, I got to see a triple jumper come back from an ACL tear, and I want to say within 6 or so weeks she was already back to doing her jumps again, whereas I'm pretty sure a few years before that, this was kind of the early days of like get the athlete back to the activity like as fast as we can. This was like 12 years ago or so now. So it was just kind of in the wave of like, all right, we need to actually like not be resting them as long because the tissues are atrophying farther, and now we have to strengthen them, which takes longer. Whereas if we can get them back even 2 weeks earlier than what was originally put on, that you're saving a lot of atrophy time because it takes longer to build it up than it does to atrophy. So that was a cool example, and that was one of the surgeries I got to see, like sit in on, watch the surgery, see it happen. She was one of my clients that I got to see through all of the process.
It's definitely cool when you get to watch it. And then tell them that you watched it.
I watched her do it for the first time, and I remember just having this moment of like, oh my God, I hope we're good. And she was just so thrilled after she did it. She was like, yeah, that felt great. I was like, here we go. We're good. Just, we're not going to do a ton of reps of it today. It was just your, kind of test it out phase. We'll see how you do the next day or two. And then, hopefully we're solid to keep practicing now.
Yeah.
But yeah, it's good. Same thing. I know hip replacements, they're getting people up and moving. I don't know if you know probably more specifically how fast, but I know it's very quick compared to
Well, they're walking like day up.
That's what I thought. I was like, before the night falls.
Yeah, within about 2 to 3 hours.
Yeah,
like
so that's even sooner than I thought. Yeah, that's
as soon as the anesthesia wears off, they're pretty much
like, move it.
They're like, they're awake. They can, they can walk
good.
while they're awake, kind of thing.
Great to hear.
The ACL, funny enough, I had this was a couple years ago. I had a patient, and I was used to the ACLs that come in a wheelchair kind of thing or crutches, and it's a kind of a lengthy process.
Yeah.
This guy came in. He came in with the crutches because the doctor told him to, but he was like walking fine, and the surgeon had no protocol. Like no weight bearing status, nothing. They just said go ahead.
They just said.
And I called the surgeon and I'm like, hey, do you have any like protocol you want us to follow? And he said, no, he's good to go. Like weight bearing is tolerated, no limitations. I was like, no limitations. And this was like a week post-op.
I was gonna ask about how far. Okay.
It was a 1 week post-op.
That's
and
great.
And he owes a workers' comp too. So it was even more like you got to be careful. But he had to get back to work as soon as possible, and he was like doing like long arc quads and like doing all these exercises. And I was like, all right, I guess we'll go through the workers scenario. And he had to be able to like climb up ladders and stuff. So like 2 weeks post-op, he was climbing a ladder and
that's crazy.
he was jumping off a box, which is something totally I would never do. I was like, this is the most strain you could ever have. And he was fine. And I was like, okay, you're good to go. And send him back to work. But yeah, that was, that was the wildest
That's experience. A really quick response.
I was so scared.
Do you know if he was doing any sort of like peptide intervention in conjunction with? Not that you're
No. It was kind of more like lawn care, working class kind of area. It was just got to get back to work.
Yeah.
So.
Fair. But a testament to sometimes getting it moving earlier is definitely the best way to keep the joint happy, keep the tissues around the joint happy, and not let that tension and protective stuff solidify your joint and kind of lock it up. Because I know I've heard of people having to go in and get like scar tissue broken up and stuff because they left.
Yeah, manipulation under.
They left the joint too still too long, and now they can't move it back, and it's a little tough to get out of. And they have to knock you out in order to move it because it's literally breaking the scar tissue up as they're remobilizing you now, basically.
Those are pretty fun. Doctor basically, the surgeon will measure it and tell you what the measurement is, and then they go back to PT and you have to like try to get it to that measurement.
Yeah.
Because inflammation kicks in after, so.
Heck yeah. What would be something that sounds safe, but actually would slow down your healing? So like maybe something a lot of us are doing when we get hurt, but maybe isn't actually the best thing for us.
Easy ice.
Ice?
Yeah. Well, like rest and ice and all that stuff. We learned like the whole method, the rice method. Yep. Yeah. And I think they changed it, didn't they? They added one more letter.
Yeah, I'm trying to.
Did you hear something about that?
I had someone tell me about it. I don't.
It was like one extra thing they added to it. But either way, I think rice or our idea of ice, because I get patients that'll ask me like, when do you ice? When do you heat? Which one should I do? Everyone's telling me something different. Their doctor told them to ice it every single day, stuff like that. Yeah. But like what ice is actually doing. And it just depends on what the injury is and their stage of healing and what happened. Really, I think ice is just hindering it in general, because all the ice is doing is just either tightening up that muscle or it's reducing the inflammation in the area. And depending on what's going on, like if it's just tight muscles is causing the pain, or just maybe something like a tendonitis in the area, ice I recommend if it's like you're having super high pain and you just need something to get it down and you're not taking pain medications, get that numbing effect of the ice. But other than that, it's just kind of hindering the healing process, because you kind of want the inflammation to get into those tissues and stuff.
It's not a bad word.
It's not a bad word. I recommend it when it's outside the natural. So like you had surgery or you had like a joint replacement, your body's gonna inflame like a lot more because a foreign like situation happened to the body, or like a foreign object technically is now in the body.
Yeah, for a full replacement especially.
Yeah, your body's gonna react differently than just a normal like hitting your knee or a twist or anything like that. So if your inflammation is like if the inflammation's actually hindering your healing process and stuff or becoming an issue, that's when ice is important. So like after operations, that's when I recommend it. Or if it's just getting so inflamed, because that also starts to inhibit the muscles around that area too.
Right, like if it's actually like softball size, you're like, okay, maybe that's a little big enough, put some ice on that.
Yeah.
That's a little bigger than you need.
They say the joint of fusion actually inhibits and weakens all the muscles that attach to it. So quads, hamstrings, calves all become inhibited as that knee swells up. So it makes it weaker, which makes it more susceptible to injury. So, but typically I say just like heat, but really heat also doesn't really get down into the tissue level. It takes too long and it doesn't actually cause the same effect as just warming up the muscles through blood flow exercise.
Through blood flow things.
So,
yeah, I'll tell everyone, I'm like, if anything, I would almost rather you sit with a heating pad around your elbow. If you're gonna do anything.
I was like, there's less harm with like a heating pad.
Yeah.
So.
And if anything, you're just encouraging a little bit more blood flow than would have been there already.
Yeah.
But I do have some clients where I'll recommend they get like some of those, like you can wrap it around your knee. It's like a strip that's the LED, or not the LED, the red light therapy stuff. And I'm like, if you want to get something that maybe could help accelerate the healing a little bit and you're just hanging out watching TV, a heating pad and or the infrared mats sometimes can be nice and get that little extra tissue penetrating effect from the infrared can be nice, at least if it's more of like the superficial tendons and ligaments. If it's a deep joint thing, I don't know that infrared penetrates quite deep enough to really hit tissues that low. I don't know if you have a little more thought on that.
I'm still doing a little bit of research on that, like kind of the effects of like red light therapy on that, like inflammation and stuff. I've seen some benefits when it comes to inflammation, but it just depends on the area and what, if they use that testing for like humans or if they use it for mice. Still, so far, the best evidence with red light was mostly skin.
That's kind of what I've also been telling people. I'm like, and that's what when we talk about the difference between different types of saunas, I'm like, well, the infrared is going to hit your skin and you're going to have a little more benefit on the cellular level for that versus like a wood fire or a deeper heat feeling.
I believe, the infrared, it's what it kind of heals you or heats you up from the inside.
The infrared, it seems, is more actually superficial. So you're getting a little bit of a heating from the impact of the light on the skin cells and the tissues underneath and encouraging an upregulation of cellular processes. That's a little bit of what I've taken from what biooptimization does with some of their modalities. They would be someone, maybe I'll ask them this question next time I have them on to kind of go a little deeper into the red light benefits, because I know they go into different hertz, what 10, 20, and 40 hertz does versus flashing versus still.
I'm still new to a lot of that. I was doing like a little bit of research on it, but just because it's become popular.
More and more popular. Yeah. I think there's some good benefit to it, but I do think in the aspect of the sauna thing, I think the deep heat is where you're going to get a lot more of the heat shock benefits, but the infrared saunas are going to give you some more of the benefit to your skin, benefit to your eyes, good hair, and like the conversion for your cholesterols and all that is, happening when you get sunlight, but that's partly the benefit of the sunlight is the infrared part of that spectrum.
I also saw that something about for some of those effects for like the sweat and detox, it actually has to reach 200 degrees, and the infrared saunas can only reach like 145.
And that's one of the things we like about having our wood fire sauna here is it does hit the 190 to 210 range, so you can.
You got the hats.
You can hit the hat.
Stuff,
the hat, so your hair is protected, and you can get into that little bit deeper heat. And it's the higher temperature, so it really allows that body to get the benefits of that more extreme feeling.
So overall, I think that kind of stuff like the ice and everything, it just kind of slows the healing process and stuff. And I think just not returning or not trying to retrain yourself to return to whatever caused that injury in a sense, or that sport that it happened in.
Yeah, the icing,
slowing you.
That was a huge thing when I was in athletic training, is still just people icing themselves all over the place. And now after the fact, I'm like, I don't know if they're still that crazy about it now. Hopefully they've kind of come to understand the same thing.
Because you guys are even in like the very acute phase, like within minutes to hours. Like it hasn't even inflamed yet. Like endorphin or adrenaline, endorphins are all kicking in and stuff. So like you haven't even had a chance for ice to even do anything.
And like they, at the time, were still encouraging athletes, like after a training session, go see the trainers and get ice on the knees or the elbows or whatever the things are after practice, and just like it was just a standard to just go get iced up after practice and stuff. And I'm like, yeah, I don't know that should be in practice anymore. So.
And then at the same time, they say drink your protein because you had micro tears in the muscles. It's like, but we have to ice after the micro tears
to keep the inflammation from
to keep the inflammation from repairing the micro tear. Yeah.
Yeah, inflammation is not a bad word, everybody. It is just a process that happens in the healing phase. It is something, if it gets too much, it can have harmful effects. But NSAIDs, most people are taking those way too often. Finding some ways to mitigate the inflammation without needing to take something as much as you can. I encourage, especially now that they're finding out Tylenol and ibuprofen are having more and more liver and kidney challenges for like people who take it daily.
But like now it's like with pregnancy.
Yeah, that was the new one with Tylenol, and what was it, autism or rates or something with pregnancy, or was it something
well,
else?
I think they're still researching that, but I think they're now recommending not to take Tylenol if you're pregnant, which previously they were not. So
I know it's going to be an interesting one to keep tabs on.
But hey, I mean, I'm all for them at least starting to advocate kind of against some things that could be at risk and everything like that, and also freedom of health choice.
Yeah,
it's becoming more popular.
Absolutely. We'll kind of wrap up soon with a couple hot takes. I think one of them here is perfect form overrated in rehab.
I feel like we talked a little bit about that with the posture thing, but yeah, I would say it's overrated. So a lot of my patients that I have come in, pretty much of any age, I kind of have them try a squat, and then I train them on the squat depending on what I want them to work on more. So everyone has this like knees over toes kind of ideology of like, oh no, we can't do knees past toes. And then there's people that are like, oh no, knees past toes are like the best thing. And I'm like, most of my patients I have like, don't let your tibia come forward. So basically forcing them into a posterior dominant squat. And I always tell them, I said like, either if I have them do that or if I want them actually to get the knees past the toes for that kind of anterior balance aspect, I just tell them like, I'm going to tell you how to do this, but this is not exactly how I want you to do the squat forever. This is just how I'm training you for this exercise right now. And I said, this is not the form that I'm forcing you into. You can squat however the heck you want, but I want to strengthen this aspect. So that's why I'm going to make you do it this weird way.
I'll point out, I'm like, and you're going to notice, especially if this is someone who's not familiar with the weight room, I'm like, you might see a lot of people squat way different than I'm having you squat right now. But I'm having you squat this way for exactly what you said. There's a very particular thing I'm trying to strengthen. That's why you're squatting this way. But it doesn't mean that it's the only way you should ever squat. It doesn't mean if you squat this type of way, it's going to be bad for you or any of that kind of thing. It's not to be dogmatic one way or the other over.
Well, with calisthenics, like you teach them one way to do a squat, they're just, I have a feeling they're probably going to not be good at calisthenics. Like landing's going to be terrible, like everything's just going to be bad.
Another hot take, I know this is a little more current events related, and this might be just a little bit more nutrition related, but we just had the food pyramid get revisited and finally get swapped.
They just flipped it upside down.
And I love that they matched it exactly how South Park predicted like 5 years ago. They literally, it's an inverted pyramid now.
It's upside down.
But it's very good to see, and I don't know how much coaching you do with your clients nutrition wise, but when people are healing, it does have an element, kind of should be at least talked about, and encouraging people like, you need protein to survive. You need more protein when you're training. You need more protein if you're healing from stuff. So now, I don't know if you have already kind of encouraged your clients to make sure like you are eating enough protein, right? Or is that never really come up?
My more like athletic like patients, I will get into the topic of that. Typically, if they're also like very heavily focused on like that sport, or they really want to improve, that's when I get more into those details, because anything could be hindering them, and nutrition is huge, especially runners. Runners, it's really big right now that I work with them with nutrition, because there's only so much I can do, but because outside of my sessions, they're running like 20 plus miles in a day, it's like, it's huge if they're eating enough. Or really, I'll sleep a lot. I ask them stress levels and sleep. Probably more than the nutrition. And maybe that's something I need to get better at, is talking more about nutrition.
Sometimes with my pain people, it does take a little longer before it comes up, because it's really like, okay, you're not healing like we should be from these moderate to low intensity sessions that we're doing. So something's not recovering right. That's kind of when I might notice. I'm like, okay, I'm gonna ask them about more nutrition stuff. Even though you didn't come to see me for weight loss and diet checks and this and that, I now think it's part of the healing process that's not happening. So I do think it could and should maybe be something that more physical therapists maybe think about a little earlier, because it's only gonna help them heal faster if they have all the right building blocks to help put that tissue back together. And if you find out like, oh, you're completely under eating protein, you're maybe hitting 40 grams of protein a day, well, there's almost no way you're really gonna get that tendon to heal. It's gonna constantly be underfed the things that it needs to build. So those can sometimes be things that people don't think about when they're dealing with these just nagging little things. Is like, well, maybe I'm not actually fueling my body right for what it's going through right now. And it could be sometimes just a little more protein, or maybe we need the joints to be a little more lubricated, and you find out this person doesn't eat any fish, they're not well at hydrating themselves, and they don't take fish oil supplements. So like, well, no wonder your joints are giving you, so many issues. You don't intake any omegas or any of these helpful things for your synovial fluid and these other processes to function well. Yeah, maybe just a little bit of a thought. I know that's kind of one thing I was unsure how many physical therapists even think about that, because it does probably feel a little like, oh, that's personal trainers kind of deal with that. That's more their wheelhouse. But more on a recovery side of things, I think it could be something that's missing in more people than we realize.
I think it's something that we forget about because we get so like, we're here for the physical therapy and that's it. And now that we're starting to become like almost primary care physicians in a sense of that, we're the person that they come to first. We're the person that they tell everything to because maybe their doctor didn't listen, or they didn't go to that doctor as much. They don't get as much time with that doctor.
That's
whether or not they listen or not, it's really, even if that doctor really sat down and listened, they still spend like, their sessions are probably like what, at most 20 minutes, 30 minutes if they spend a lot of time with them, where our sessions are like an hour. So we do spend more time with them. We see them regularly, like twice a week, 3 times a week. So like we get a lot of time with them. So I think it's maybe becoming more common for them to start talking about their nutrition, their weight, their stuff like that. But it's something that's probably starting to phase in
a little bit,
stuff like that.
And I think that's good. I don't think it needs to go all the way into the food logging and all of this craziness. It's more just bringing awareness to just, you're focusing on protein, right? You're getting what we need to heal, right? Oh, you only eat 1 egg a day and that's about your main protein source? Like, okay, well, we could probably do 2 eggs a day or anything.
I've had to ask some because if they're skinny, more skinnier and malnutrition is kind of a concern, ask like, did you eat today? Like, how much did you eat? Stuff like that. Because sometimes they come in and they're like dizzy and stuff like that. Have you had anyone talk about creatine that comes in?
Not yet on the podcast. I know I definitely have clients that ask me about it, and it's almost becoming something I know more people are becoming aware of it because of its cognitive
I'm surprised how many
benefits now.
I have a lot of like older patients that are like, just tell me, they're like, oh, since I've started taking creatine, I've noticed like, they're like, I don't get sick as much or something like that. I'm like, okay, never heard of that before, but cool.
It seems to be some much more helpful molecule than I think people realize. They used to be that's just for bodybuilders or people who are trying to get really
Well, they thought it was like steroids.
Yeah. They're like, man, I'm just getting
like huge. Your mom was like scared if you were like, what is this? You're like, no, Mom,
my kid's on creatine.
Yeah.
I think it's a very good supplement where women are starting to be encouraged to take it more. I think the average person is even now being encouraged to take it more, even if you're not spending 4 days in the week of your week in the gym. It's more also a cognitive thing now than just a muscular thing.
That's what I've been hearing a lot, because I have some that either have like dementia or like stroke, and they get some memory issues and stuff that they're actually taking creatine. And without me recommending it, I was like, wow, that's
great. They're seeing
like
something
just seeing
in the
something
ethos
online and they're trying it and it's working.
That's
I'm like,
great.
So all props to the media for that. But
I think it goes into this whole, people paying a little more attention to the mitochondria now. And, the mitochondria is running on ATP. When we give ourselves creatine, you get more ability to get that phosphate and your cells can run a little better. So I think your brain starts to function a little smoother. Your body starts to be able to do processes faster. Your sleep gets more efficient, I would imagine. So I think there's a lot probably more, I'm surprised it's taken this long to find the cognitive benefits for how much they've researched creatine, because it's supposedly the most researched supplement, but we're just now finding this out after decades of people being into taking creatine. So it is an interesting...
We're just now changing the food pyramid too.
After
how long did that, that's been around since we were kids, probably.
Probably, yeah.
I think that's when it started, probably in the 90s, maybe.
When we were probably young, it changed to like a plate. They wouldn't show you the pyramid as much, but they would show you like a...
It was Michelle Obama, so that was like 2000, something like that.
Probably, yeah. So we were like...
they did the plate. I mean, I never paid attention to that.
I didn't as much either. I remember thinking, oh, this is how much protein I need? All right, that's enough. As long as each meal has a whole fist of protein, I'm probably good.
Yeah. I think this concept... Well, not getting into a tangent about nutrition, but mostly emphasizing because a lot of the way that pyramid is, it almost looks like everything's just kind of bunched together. And I think it's just letting people know that like we shouldn't really be strictly heavily on one food and lightly on one food, that everything should be kind of like a balance.
Yes.
So
I've always tried to toe the line with, I get clients on all ends of the spectrum, fully vegan, fully carnivore, all the way in between. And I've always never really encouraged one extreme or the other, because I do think there is some balance of all of it that needs to be there, and they're all around for a reason. So it's just finding what direction of skewing makes the most sense for your body. If you're not an athlete who's training and doing lots of extra miles, you don't need that many extra carbohydrates in your diet. Carbohydrates are easily accessible energy, and if you're not expending lots of energy every day, you don't need lots of carbohydrates. Your body needs proteins and it needs fats for muscles and for brain health and a lot of systemic function. Yep. Carbohydrates are pretty much just energy. So that's really kind of activity level dependent. And I think the top two pieces of the new pyramid is biggest.
If you think it's, you have like the vegan diet basically is that whole right side. I want to say leading up to the top bottom. So you kind of have, whether you want to be vegan or not, you kind of have that structure there, so.
And I think it'll hopefully encourage a lot more balance in the average ideology of the way people eat, and not be so dogmatic about one thing or the other, like the saturated fats and the cholesterol thing and sugar and the diabetes and dementia thing. I don't think a little bit of added sugars is the end of the world, but if you see a can that has 25 or 30 grams of added sugars in it, like that's a problem. You'll see some of these new drinks coming out that have some of the like Delta 9 in it, and some of these other recovery drinks with the ashwagandha and combinations of a lot of other things. They might have like 3 to 5 added sugars in it just for flavor enough. I don't think you need to be scared of those drinks because it has 2 or 3 or 5 grams of added sugar. It's just being mindful of, keeping a balanced diet overall, and
balance in the source of that sugar too.
Right, exactly. And check, is it raw cane sugar, or are they using like
cane
sucralose
sugar?
And
Sucralose, stevia.
I've heard some interesting stuff on stevia recently too. Something about hormonal challenges with that, and that's supposedly the big natural one that a lot of drinks have defaulted to. But now it might be showing some sort of
like similar to sucralose effects.
So I'll be interested to keep tabs on.
I've noticed some people that can't take the stevia because of the similar stuff that like sucralose caused.
I just don't like the taste of stevia myself.
Yeah, if you take too much of it, like I notice I get a headache.
Really?
If I take too much of it. So my wife gets a headache.
Yeah,
so
it's not
kind of similar to like sucralose if you take too much of it.
So it's best to just listen to your body with all of the things food-wise. We're all a little different here and there, and being your own scientist, I know is a big thing that BioOp is a proponent of, and it really takes you being the one listening to what you're feeling, because you're the only one experiencing it. So being more specific on the word choices, being more specific on your communication with your practitioners all helps your process. It's a good point to wrap up at. I know we've been chatting probably a little over the hour mark, so I think it's
for
a good
the 45-minute podcast.
Yeah. Well, appreciate you all for listening. We will see you next time. This has been the Return to Play podcast with George Pappas of Pathos PT. See you next time.